Great. Now I'm excited to welcome and introduce our presenters for this afternoon. We have Kevin Moore, CEO of United Healthcare Community Plan of Wisconsin, and Phil Stahlberger, the Vice President of Public Affairs at NTM. NTM has been a longtime supporter of MHPA as a bronze partner, and we really appreciate their continued engagement and support of MHPA and our member plans. Kevin and Phil will be presenting today's webinar titled Driving Positive Health Outcomes Through Flexible Fleets. With that, I'll go ahead and turn things over to Phil and Kevin.
Hey, everybody. Thank you for your time. I appreciate taking time out of your busy day to join us today. We're going to do a little different here today. Couple of housekeeping things that I'm just going to add on to. If you've got any questions during the course of the presentation, please just add them into the Q&A. We want to be able to answer them or get to them in real time. Sometimes it's always difficult to come back later on in the presentation. So please feel free to add your questions, comments. If we miss something or something needs to be clarified, let us know. But I'm excited about this presentation because I get to introduce a good friend of mine, Phil. Phil's had over 25 years of experience in public affairs, strategic public relations, government affairs, and also in business development. He started way back in the Minnesota legislature working for the Minnesota Senate. We will try to minimize our Wisconsin, Minnesota jokes to well, at least a half dozen. He then served as Director of Legislative Affairs for the Department of Commerce, and then later joined Blue Cross Blue Shield of Minnesota, and eventually became the Vice President of Policy and Legislative Affairs for nearly 13 years. Later on, Phil joined a multi-state law firm of Fairey Baker Daniels and managed over 15 different clients across the country, including medical transportation management, also known as MTM. Based in St. Louis, Missouri, which is now based in St. Louis, Missouri. Phil was chosen by MTM in 2013 to create and lead their public affairs department. Since joining the company, Phil has helped organizations triple its footprint throughout the United States, which now enjoys operating in 33 states. Phil also co-created a national association called the Medical Transportation Access Coalition, affectionately known as MTAC, to provide a voice on national advocacy efforts for medical transportation issues in DC and across the United States. I've known Phil for over 10 years now, and I can tell you that hopefully you'll not only learn a couple of things today, but you'll also hopefully have a little bit of fun this afternoon as we look at what is really a critical component of our delivery of healthcare services, but as we're going to talk about even more than that. So I'm just excited to be here. Now, Phil, now it's your turn.
Yeah, thanks, Kevin, and I appreciate MHPA's continued commitment as well. When Kevin and I decided we were going to introduce each other, I didn't know he was going to write my entire LinkedIn profile. It's not fair, Kevin. It is what it is. As Kevin said, he and I have known each other for a long time. As you may or may not know, Kevin's the CEO of Community Plan of Wisconsin and Illinois. Prior to that, at United, he was the Vice President of Strategic Solutions and was also the Vice President of National Policy and Strategy. So clearly, Kevin is I'll say, a brain trust in the Midwest on United's front. So I've known Kevin since he was Medicaid director, and I will say this: MTM is in 35 states around the country, and if there's one epitome of that, and really appreciate the work he did working in state government, then and his background continues to go back to the Governor Walker administration. And we can tell jokes, but that Governor Walker and Governor Plenty had between Minnesota, Wisconsin for years. So Kevin comes with just not just a great resume, but he's a great person, and he's always got a great breadth of perspective from United. So we appreciate that and appreciate United's commitment to this webinar as well. So thank you, Kevin. This is great. So today we are talking about obviously non-emergency information. I think everybody knows it's a difficult landscape for transportation providers. It's hard to meet demand. Medicaid plans, as you hear, they want a solution for transportation, and we continue to evolve and grow. And I like to tell the story that MTM started in 1995 with one fax machine and one contracted van. That was technology back then. Obviously, things are changing honestly on a daily basis. And we're going to be talking about a flexible fleet that leverages different types of transportation all across the spectrum. So we are anticipating a vibrant discussion here. I know Kevin will have lots to add as well. When you think about the demands of transportation providers. Obviously today there's a lot that people are faced with. Increasing costs associated with gasoline prices, increasing costs of insurance. And when I'm talking about transportation providers, we have to have a pretty big network. Our network has to include wheelchairs, Lyft, Uber, taxi cab, trains, planes, and automobiles, if you will. And the landscape continues to be more difficult. Again, rising fuel costs impact a lot of transportation providers. Inflation is a huge issue. It's a tough business to operate. We get that. The traditional transportation provider today faces issues they didn't have maybe 5, 10, 15, definitely not 25 years ago. So we know that the landscape is going to continue to change. And Kevin, I'm not going to add anything, but I think you could probably say that to other provider groups as well.
Yeah, I think this is something that, as we look at NEMT in particular, thinking about the one on the upper right-hand corner here, where just being able to budget, thinking about how we set either as health plans or as health systems, and just knowing the volatility, just adding in the influx and the immediate changes around fuel costs. It's a new environment that I think means we need to be thinking smarter. We need to be thinking more innovatively, but also understanding that at the end of the day, whether you're a plan, a provider, or an NEMT vendor, or a transportation provider, how is the member still remaining the center of what we do, so that we're being efficient, we're being respectful, we're being competent to their cultural needs and their individual needs. And this is something I think, while we're talking here about NEMT, it's really transcending now in this new post-pandemic world, I guess, as we're emerging out of the heat of the pandemic, of what we need to be thinking about, not just in the next month, but what we need to think about in the next 6 months and 1 year, and sometimes even 5 years as we think about system transformation.
Yeah, and when you think about, I think we as MTM, what we've been doing and trying to do going forward is really, we're changing NEMT. If you don't like, I think the old adage is, if you like healthcare, give it a day or two, it's going to change. And I think we're seeing just that. As healthcare changes, so does MTM. What are we doing about it? And I think we're trying to come up with, new delivering people to and from their employment. The old adage, and Kevin, as Medicaid director, I'm sure you're going to have some experience with this as well, but the old days of what a transportation provider looked like, what I'll call an old broker looked like, is much different than it is today. The pandemic had a huge impact on the traditional providers. I think we found out who was really in it and wanted to be a sustainable transportation provider. As hospitals closed around, especially in rural parts of America, you saw there was a bigger need to travel farther distances, and we can talk about some of those pain points as well. And again, both as an MCO, Kevin, and also as a Medicaid director, let's face it, service level expectations are continuing to rise. People want more, they want to pay less, and they're not willing to kind of put up with the normal complaints. And so we know the demand is growing due to so many different factors. And having said that, and I think many of you know on this call, our acquisition of VEO, I think, was a prime example of we're going to continue to grow as MTM, whether we're going to build it ourselves or whether it comes through acquisitions, mergers and acquisitions. So we saw what I think VEO was doing, and I think we really appreciated what they were doing, and it kind of brought a new, fresh approach to just the whole network, and we'll talk about that in a little bit.
And you know what, Phil, I think one other thing to keep in mind as we think about the evolution of NEMT, I think it's also, we always think about what's going to come next, but I think sometimes it's also an opportunity to reflect back and thinking about how NEMT as a SDOH benefit within Medicaid in and of itself was innovative, even going back 10, 15 years. Medicaid understood that if we really wanted to close gaps, if we wanted to get people into seeing providers, particularly people that are living at or below poverty level, transportation is always going to be a barrier. And so to the extent that we've seen NEMT now even moving through MTAC and some of the advocacy that was done at the federal level to now codifying that as a Medicaid benefit, I think it really now is a reminder of just the role that Medicaid managed care can play, the role that NEMT can play, but the important role that transportation plays in not just the clinical health of our members, but also of the health of a community, being able to connect and close social determinants of the health gaps. So it's one of those things that the evolution, NEMT was probably, as an SDOH benefit was innovative before we even knew what SDOH was. It was a kind of this practical thing that now we have to continue to evolve and improve upon if our goal is to really, again, meet the members' needs and making sure that they're living their best lives.
I thought we couldn't call it SDOH anymore, Kevin. Isn't it now called health-related social needs?
For now, until that changes again, right? It's the 80% of
Right.
life that's not within the four walls of a clinic or a hospital. It's what we call, my old boss used to call it, it's just good old-fashioned social work. It's being able to connect to issues. So definitely, whatever you call it, it's definitely the next issue that we have. Transportation is going to be key to that.
Agreed. And I think, we're going to talk a little bit about Wisconsin next and kind of what you are experiencing or have done.
So just to kind of level set with everybody, Wisconsin is a carved out NEMT benefit. We have one statewide broker, but then also Wisconsin also has kind of a number of different delivery mechanisms to be able to provide services. So we have 14 Medicaid HMOs that serve our Badger Care Plus population. This is going to be TANF, CHIP, and childless adult populations. We have 7 Medicaid HMOs that serve Medicaid SSI. And then we have 4 MCOs. So contrary to other parts of the country where an MCO and an HMO are a little bit different, our MCOs are aligned with our family care programs, which are our long-term services and supports. We do have Medicaid managed care, whether it be long-term services and supports or through Badger Care and SSI through all of 72 counties in the state of Wisconsin. And as I mentioned, our one statewide broker, which right now is the combination of VAO and MTM, they are now providing services for, and if we want to move to the next slide here, basically kind of a quick snapshot of the volume, and keeping in mind that these numbers are always fluctuating, especially now that we live in the PHE world where membership can go up and down, or up, I should say, pretty frequently. But you can see that from a utilization perspective, from the number of members served to the number of legs completed, while we may have a carved out program, the ability for managed care organizations to really align with a transportation broker, and again, and whether it's carved in or carved out, it's really about identifying the members' needs. It's making sure that we can get them the information that they need to get a completed trip so that they can get to where they need to go. And then also creating that feedback loop so that as whether we're doing care management for somebody on dialysis or somebody that's doing chemotherapy to somebody who's just trying to get to a doctor's office for an annual visit. The ability to really bring data together to be able to partner. That's part of the reason why it's so great, even though it's a carved out benefit. How do we have at the health plan level, how do we have as much information, as much data, as much interoperability with our NEMT vendor and partner so that our care managers know what's going on the transportation side, and to the extent possible, our transportation our team partners over at MTM and VAO, they understand what we're doing to support our members. So again, there's different models. Every state's going to be different, just like every Medicaid program is different. But conceptually, I think it's how do we provide those transportation services, getting people to where they want to go, while also understanding that at the end of the day, we want to be incredible stewards of limited resources, financial resources, and human capital resources that are provided for our state Medicaid partners. So I think we've got, Eric, a poll here. I think we're on poll question 2, if I remember correctly. So folks want to take a minute here. And again, just a reminder, as folks are filling out the poll, feel free to, if you got a question, comment, let us know.
Keep it open for a few more seconds, and then we'll go ahead and show the results.
Well,
There
I
you
think
go.
what we call a landslide. Great question. Thank you all for responding. Totally agree. The transportation in general, I think as we saw through the pandemic, through lockdowns, through just as we all were adapting, whether you're on Medicaid or not, the role of transportation, it became compounded, not only in terms of being able to get people where they needed to be, but thinking about just who's going to provide the rides. Both of those became incredible challenges. So I'd like to share with everybody a case study that's actually ongoing right now in Wisconsin. We have a number of requirements that we have with our state partners as it relates to performance improvement projects. And for us, as we're looking at our performance improvement projects, we're always looking at it through the lens of equity and looking at it through the lens of trying to address disparities for certain cohorts and populations that we serve. And so for 2022, we specifically focused on our Spanish-speaking SSI members, and that we were trying to identify different ways of controlling high blood pressure. And again, we were very fortunate that we had a broad swath on what could we do, how did we want to engage with this population, what were we looking to measure. But because we were looking at this through not only a clinical evaluation of how do we control high blood pressure, but we also wanted to make sure that we were really looking at it through the lens of equity. The first thing that we wanted to get around in addition, as we were extracting our kind of our clinical data from claims, was we wanted to get a better read of what were the social barriers, or what was the SDOH, or whatever the word du jour is, if you will. What were the SDOH barriers that our populations under this performance improvement project were facing? So what we did is we did what most of us do, right? Like we looked at identifying a screening tool. We went out, we asked specific questions around key domains. And again, here are the 4 big domains that we have: food insecurity, insufficient housing, transportation access, or proper utilities. And as many of us know, we could have actually gone through education. We could have added a number of different ones. But for us, we wanted to really identify some of the, not just the SDOH barriers or domains, but also understanding that we wanted to find out if there are ways to connect to specific services on the backside that really could drive. In this case, we wanted to get better engagement with providers, with our Spanish-speaking members, but ultimately we wanted to bring high blood pressure rates under control. So after we did our survey, you can see here that without a doubt, the number one issue that came out of the screen was transportation. And to a certain extent, I'll be honest with you, I think a lot of us were a little bit taken aback by it, not because it was the number one issue, but I think it was the magnitude of 63% of the respondents saying that transportation was the biggest barrier. Now, I will say a couple of caveats about this. As we think about transportation, where we were trying to do is really convey that this was that kind of the transportation to the provider, to the doctor, to the clinic. But we also recognize that transportation could actually be more than that. Depending on how somebody's thinking about, well, I can't get to the doctor, but I also can't get to work. I can't get to the doctor. I also can't get to school. I can't get to pick up my kids. So we understand that there's still more evaluation and that we can do to really dig into what that 63% looks like. But again, 63%, 20% said food insecurity, housing insecurity came in at 9%, and utilities at 7%. So what does this mean for us? So a couple of things. First of all, it really made us more aware of the need to better align our care management approach, whether it be a community health worker, an RN, an advanced practice clinician, making sure that we have the resources and tools to help navigate with our member, with our NEMT partners, so that they know how to get a ride. They know how to connect into the platforms, the portals that VEO and MTM bring to the table. It also means, though, for us as a health plan, we now need to be more revved up and educated on what are the tools and resources and how can we be more proactive in identifying and throwing it over the wall. It's understanding that we also need to be able to set the ride. We need to be able to track that ride, because as we're able to track with our member, whether it be transportation, whether it be going to the doctor, whatever the contact point is, each time we're actually building out a better opportunity to build rapport, better opportunity to build trust and then also deliver on the health results that we're looking for. So for us, I think it was a great opportunity to see now, and we're actually in the process of looking at the technology that is available, training our team members. We're actually going through training over the course of November and December with the goal of being able to deploy software that is available through MTM with our care managers so that we can see in real time where the rides are scheduled, are the rides being delivered, all of that then so that we are supporting the transportation that MTM is bringing, but then also we're also being able to provide a heightened level of service and support for our member, because ultimately our goal is to make sure that they're getting their trip to the clinic. And in some cases, it's also what do we need to do next? How do we continue to build on that trust as we think about health outside the four walls of the clinic? I think Ashley will move over, and I think Phil, you're up next.
Yeah, and Kevin, I think when you look at expanding adequacy and independence, I mean, I think we've really taken a look at how the traditional NEMT model is going to change, and as I spoke earlier, it has to change. The traditional transportation provider fleets are great. The folks that we use on a day-to-day basis. Again, I think through the pandemic, we really found out which ones were really serious about doing this kind of work. And so we highlight a lot of those as MTM, kind of the traditional providers who continue to do good work, and they have been doing it for a long time. We also work with a lot of ambulance fleets around the country, depending on the state that we're in. Some of them use more or less, and we know ambulance companies have their own issues, and that's also a tough business. And then we have our TNC fleets, which transportation network company fleets are either Uber, Lyft, in our case, our own IDPs, other forms. And let's face it, even a state like Texas, for a while, we were in Texas, they didn't allow Uber and Lyft, so to use other forms of TNCs. So there are lots of different TNCs, and I think the technology that we've been able to build in the back end can pretty much accept whatever new technology comes into play. And I think that's important to be a plug and play company ready to use whatever technology is going to be thrown at us. So those are the first three models we'll change looking at. And then when you get into kind of the, through other fleets of innovation, this independent driver provider, or you heard me say IDPs, that fleet does come from legacy Veo. And it really was a way for us to look at how do we create an Uber, Lyft, a TNC type atmosphere for Medicaid patients. And that is that model we're talking about. And that has really been, I think, will be a robust way for us to continue to improve, increase, and expand our current fleet. And especially in, let's face it, in a lot of states, the metro areas is where most of your Medicaid members are. And so when we look at those kind of fleets, that's generally where they're going to be located. We know there's not going to be a lot of, IDP drivers, in rural parts of America. That's going to be a little tougher, but this is one way that we can help with this. We're also looking at dedicated fleets of wheelchair vehicles, and I think this is going to be in a new and exciting way. And we'll show some graphics here coming up where we could literally have dedicated fleets of wheelchair vehicles. And when I'm talking about IDPs and dedicated fleets, these are people that really want to help Medicaid, and their primary focus is Medicaid. A general TNC, they're transporting anybody and everybody to the airport, from a bar to a business, whatever the case may be. When we're looking at IDPs, they really are the people that are focused, like Medicaid is first. The patient comes first. To your point earlier, Kevin, is, we want people who are in it for the right reasons, which is the Medicaid member. And that's what these two fleets, I think, as we grow, that's what we're hearing. Is people don't want to hear complaints. They want people to focus on the member in the back seat and really look at them and treat them with kid gloves, frankly, to make sure that they're taken care of. We also, through technology, and I'll get into this a little more, gas mileage reimbursement, or GMR. It's a personal fleet. Let's face it. You're going to have probably fewer complaints if you're driving yourself to your appointment, or if a loved one is driving you. Hopefully you're not complaining about your own driving. It happens. But this type of technologies, we can actually use apps for people to, instead of doing it on paper, trying to eliminate paper, and let people use their phones to track mileage, submit a claim, make it easier, make it more accessible for people to get to and from with their own personal fleets. And then public transportation, especially in places like Madison or Minneapolis or St. Louis or Austin. Pick a metro city in the United States, and we're going to have more public transportation than you are in maybe, the rural parts of America. But, our goal is to make sure people get to and from the most effective means necessary at the right price. And sometimes public transportation is a great way for members to not only get to and from their medical appointments, but also be a little more independent. And I think we're seeing that through our own training of people being able to use public transportation. So all of these are going to be expanding adequacy and independence, not just for us, but for the member, but also for our clients in states and MCOs. It's going to make sure that we've got a robust network in hand. And you can move to the next slide. Yeah.
Actually, let me just add what you had just said. I think it really becomes important then, whether you are a Medicaid MCO or even if in a fee-for-service state, thinking about not just the traditional modalities of getting people rides, but thinking about all of these new innovations that are coming online. If your care managers, your CHWs, your peers, for example, having them to be able to understand that there may be more than one different way of being able to get a ride, that just creates, again, it's all about creating trust and being able to provide that engagement capability. And so it's as these new technologies come out or these new modes of transportation, I think the transparency between payer, provider, and again, I don't want to lose sight of even the provider systems out there, just making sure that everybody's kind of all on the same page of understanding that the goal is we want to get the person to the clinic. We want to make sure that they're getting the ride, whether it be gas reimbursement, whether it be public transportation or a wheelchair vehicle. The right ride will always give us a better outcome in the long term. So as the technology moves forward, it's really imperative that we continue to learn and to embed that technology and those resources into our care management approach for our members.
Yeah, and we recognize that, as an MCO, you're trying to make sure you're taking care of the whole person, right? And transportation being a part of that, absolutely. When we look at, again, I'm going to use the acronym, the new acronym IDP, the independent driver concept. When we look at, we know through our own data analytics when people travel the most to their appointments. And so what we can do is with these IDP fleets is actually make it a little more robust than normal to make sure we have over coverage. We talk to our transportation providers, traditional transportation providers, a lot. And a lot of times they can maybe be completely fine with maybe their region or the number of trips or kind of who they serve and where, and they don't want to expand. We can help them expand, but sometimes they're just fine doing their own business and keeping it the same. But we also know that as the population grows, as Medicaid roles have expanded, so too are the number of trips, obviously. And so this graph basically shows, certain times of the day that we know we're doing more trips, we can use the IDP fleet to make sure we have even more of a robust network. And I think that's the biggest advantage here is we're creating more flexibility and being able to rapidly scale what our network looks like. And if you can imagine, a traditional transportation provider would have to go buy vehicles, would have to make sure they're guaranteed trips for all day long, not just during the peak hours. And so this way really does optimize the right supply at the right time. Again, especially in more metro areas. But I think we're excited about this approach, and I think it's going to continue to grow. And it is one way. And let's face it, I think Kevin, you and I would also agree that sometimes a TNC isn't the appropriate mode. We talked about that. It might be gas mileage reimbursement. It might be public transportation. But this is just one tool in the tool drawer that we can actually look at making sure we're getting members to and from their appointments. Moving on to the next slide, I think you'll see that these IDPs, again, they're going to match supply to demand. And technology is great, and everybody loves technology when it works, me included today with my technology, my spotty internet service today for some reason. But regardless, we know that more Medicaid patients have access to this technology. They want to use it. Therefore, let's help them. let's make sure that through our predictive analytics, we can use these IDPs to show exactly where members are, where they need to go, and place vehicles in the right place at the right time. And again, some of this, is both nerve-wracking to folks, to some people who may not be used to technology, but also it's also exciting because, the worst thing you want to do is have a missed trip or a complaint. And I think what you're seeing is IDPs can help increase the flexibility, increase the networks. And I think, as you'll see in the next couple of slides, we're going to be talking about decreasing complaints. And I think that's also the exciting part. I know from a client perspective, Kevin, both from a state and an MCO perspective, that's the worst thing, is having more complaints. And this is just a quick graph, and actually the next two, both of these next two slides are just an example of when we go into a new market. This happens to be California, for example, where a health plan wanted us to really use IDPs as much as we could. And you can kind of see, it's might be hard to see in these colors, but the turquoise color, if you will, that basically starts out at 0 in January and trends upward, is basically the IDP network, that as we go, we're able to use more robust networks through IDPs. And you'll see that the other green line is kind of our traditional provider network, and it kind of stays relatively flat. And again, I talked about that earlier, where it's sometimes difficult to get traditional transportation providers to grow excessively like you could an IDP fleet. So this is just one graph that shows it has worked, it does work, it can work. And this is also where a lot of communication is needed, both from our standpoint, the transportation provider standpoint, and also a client. And I think the next slide will show, as we use more IDPs in some markets, you can see that the complaints actually go down. And again, when you've got drivers that are really focused on the member, they get better service, fewer complaints, and it's just a better overall experience. Any thoughts on that, Kevin? I know you like complaints from either side, right?
Yeah, no, grievances and complaints, they tend to drive, in some cases positively, they drive policy change, but a lot of times I think True. It's also, it also identifies where there are operational and even sometimes policy issues. I mean, thinking about the role transportation plays, we've all been in situations where if we are driving ourselves to our own providers for the 11 o'clock appointment that starts at 11:15, a lot of folks have the ability and the privilege to be able to hop in a car and be able to move along and go on with our day. But if you're reliant on somebody else to be there, again, going back to what I said earlier, is having multiple different modalities is really important, because again, if a provider is running late, how can you make those adjustments on the fly so that a provider is not sitting there? Again, from a financial perspective, from a logistics perspective, that's a potential complaint, not only for the provider, but also for the member, right? But how do you use technology to not just replace, but to really develop better relationships between our members and between the transportation providers, so that as we've gotten more used to, I'm guessing if we took a poll, how many people on this call routinely use Uber and Lyft? Well, why do you do that? It's convenient. It's right at your fingertips. That's regardless of where you are in the socioeconomic status and whether you're a Medicaid member or not, the technology is here. That's how we communicate, no matter where you are. And so the expectation, we should always be looking at it through that lens of how do we really meet the members' needs where they are? How do we make sure that they're getting the answers and the responsiveness that they want? And if you do that, as you can see, whether it be this or any other thing, or thinking as a Medicaid MCO or any HMO MCO, we're always striving to be to lower our grievances, lowering the complaints, because that just means a better customer experience. And so again, how do you education, outreach, but also how do you make sure that innovation is really staying focused on what the needs of the member are? And that's again, I think this is a great example of that, but also thinking about all of the other things we've talked about around transportation. As a HMO, we love the fact that we can now look at a bigger portfolio and a bigger menu of options for our members as we get them the transportation that they need.
Yeah, and we've been excited about giving real-time data, real-time information to you all from a client perspective, but also it's helpful for us because the worst complaint is my driver didn't show up and therefore it's a missed trip, right? That's the ultimate worst one. With this new technology, using GPS, using the IDPs, Oftentimes if the member has a smartphone, you can see they're on the south end of a hospital and the driver's on the north end of the hospital. And how do you connect those two? And if they call us and say, hey, my driver never showed up, we can say, well, actually, they're waiting for you on the other side of the hospital. It's a beauty what technology can solve. So that would, take the place of a complaint, because one, you're able to communicate both with the member and the driver to say, hey, Mrs. Jones is on the south side of the building, drive over there. And I think it's been really helpful for us to not just mitigate complaints, but mitigate missed trips as well. In terms of dedicated fleets, and I think this is where I alluded to earlier, as we have dedicated fleets, wheelchair accessible fleets, it brings on kind of a new approach to kind of supplementing wheelchair accessible vehicles with kind of plan specific, plan dedicated branded vehicles. One thing I say, it does bring in a accountability factor when your name's on the side of the vehicle, both from a plan and a broker such as MTM. This is a partnership, and we take this seriously. And I think this is a new approach to making sure that some of the most vulnerable are really taken care of. So we're excited about this, and I think this is something you'll see more in a lot of different states in terms of kind of our dedicated fleets. Do you have anything like this now? Have you seen this before, Kevin?
Yeah, I think you see, it's funny that you said that. You can kind of, if you're driving, and again, depends on which market that you're in and which state that you're in, but you definitely do, you can tell this level of professionalism. And I would even argue if it's a broker doing the sponsorship, or even thinking about some of our private vendors that are doing the same thing as well. So I think it's something that definitely does help. And it brings, to your point, it brings a level of comfort in what we're bringing to the table, that this is not, for some individuals that may not be comfortable with some of the other alternatives, this is a way that they feel more comfortable engaging with the transportation system. We want to make sure that they feel comfortable, because that means they're going to be continuing to be engaged in their healthcare outcomes, which is ultimately what we're all looking to do, whether you're a broker, whether you're a provider, or whether you're a Medicaid health plan.
One place we know those vans won't be going to is any Green Bay Packer games in Green Bay.
Okay, we'll have to have a conversation on that.
In terms of improving quality and capacity, again, why are we introducing a dedicated fleet now? And again, I talked a little bit about that earlier, as additional quality control. I think you talked about it, Kevin, is it's when you wear your name on your vehicle, it brings up more quality control. Again, it's ideal for dense urban markets. It gives an opportunity to increase hybrid electric vehicle use as well, which is something we're passionate about. Look, maintaining vehicles is a lot of work and it's expensive. At the same time, just as we're all trying to reduce our carbon footprint, et cetera, how can we play a part in bringing more maybe hybrids, electric vehicles into the market? And this is probably one way that we can have a hand in doing that. Whether it's MTM owned and operated, we lease it to IDPs, lease it to the traditional NEMT providers. We want to have a stake and a hand in helping shape what the fleet looks like, and I think we're doing that through numerous activity. But this is just one way that there are options. Again, based on regions, state requirements. Every state's different. Not all rules apply here to your particular state, but it is one way for us to help improve quality in terms of a dedicated fleet. In terms of kind of the next slide, will show a little more into the technology of gas mileage reimbursement. Scheduling and claiming trips used to be tough on paper. How many miles did I travel? Where did I go to? How does the MCO, how does MTM, how do they know how far I traveled if I had to go, through a snowstorm or whatever the case may be? Essentially, this is a way to reduce paper logs, and this is a much easier way. Gives quicker access to revenue, frankly, for the Medicaid member driving themselves or a loved one. With the automatic GPS location verification built into our programs, it allows them to basically take a trip, click a button, track the trip, submit it, and it gets paid. I mean, it sounds simple. I know we're used to this, but in terms of Medicaid, I'd say this is it sounds silly, but it's groundbreaking, really, because it's removing barriers to care and letting the individual really have control of their own destiny. And we see there are some states where gas mileage reimbursement is probably the number one transportation way for them to get to and from. West Virginia, for example, was one state that we had a lot of GMR claims, and it's just the very nature of the business. So if we can make it easier for people to get to and from, remove barriers, it's exactly what we want to do. And I think it's this is just one little piece of technology. And you hear the big word technology and think, oh, what is that going to cost? What's it going to mean? There are probably some simple ways that we can help all patients be more efficient and help us with more data. I talked, earlier about public transit. One thing that we call it travel training, where we literally put boots on the ground in a city, in a state, and help teach those that are in a wheelchair, how do you become more independent? How do you not just get to and from your appointment, which is step number one, but now they're going to be more familiar, more comfortable taking public transit. How can that foster their independence to go get groceries, to go get whatever they need to be more self-sufficient? And we promote public transportation when it's appropriate. And it really is, again, trying to make this easy for people to get to and from. Anytime you can streamline how you do things, we talked briefly about the gas mileage reimbursement, the same thing with bus tickets. Would you rather send out 150 paper bus tickets, or would you rather refill a card or refill a phone or an app, whatever the case may be? However, we can make it easier for people to jump on a bus, on light rail, whatever the case may be, to get to their appointment. It's going to make them feel more self-sufficient and be a part of the community. That's what we want to see. I don't know, again, Kevin, Milwaukee, Madison, certain parts of Wisconsin have more public transportation, but do you think that we're going to see more of this, coming down the pike? Is this going to be a greater piece of the pie?
Yeah, no, I still go back to when I was Medicaid director. I remember a conversation where we saw a month-over-month increase in the number of individuals, number of members that were using public transportation. And what really was probably the best thing is that people really wanted that because of the flexibility that happened, whether it be the bus pass or the ability to do transfers, the ability to go to the doctor, but just thinking about how that works. So I think, as public transit continues to either grow or become more modernized, I think the ability to align how we deliver services, making sure, and I, again, love the idea of how do you mentor, how do you provide training for people to better use it. So again, that they feel more comfortable, the more comfortable that they feel, they're going to be more engaged, not only in their clinical care, but they're also going to be more engaged in maybe going to the library, going to the grocery store. Again, fostering that independence, I think, is ultimately what we want for no matter which population that we're serving. So definitely think that this is a great tool. But again, it's we've got to have we got to have all of the different options in the stable. We need to make sure that, because somebody who today feels very comfortable with public transportation, they may actually need something more targeted, more specific, either from a clinical perspective, a behavioral health perspective, a privacy perspective. And how do we make sure that we're aligning to what those needs are? And I think you're seeing, even from, thinking about 5 years ago to where we are right now, the acceleration of options that can help Medicaid managed care members in getting the services that they need through a broker model. It's really, I think the future is very promising for our members.
Yeah, I would agree. And obviously, again, as I mentioned earlier, I feel like we've had to listen more, and whether listening to Medicaid director, listening to MCO, how do we solve the problems? The problem of getting people to and from is still there. Through technology, through other barriers, we need to think differently. And I think what you're seeing is that we've done a lot of listening, and now we're doing a lot of action items and making sure that we're really trying to get at the roots of the problem, which is making sure that we get people to and from their appointments with whatever fleet we can. And I think it's an ongoing process. And, we appreciate, from a Medicaid director standpoint, the guidance you gave us saying, hey, look, here's some issues, how you can address them. And now in your current role, you have the same kind of levers And we need to be more proactive in making sure that we've got those bigger fleets, which is exactly what we're doing. And I think, again, every state has different problems, different needs, et cetera. But how can we be part of the solution is what we're trying to accomplish. And I think that takes us to the end of our presentation. Now is when I think you and I have to do a dance of some sort to until people ask questions.
Fortunately, we have a question. So that we got to say, everybody, whoever asked the question, let me just read it off. Can you actually read it, Phil, or do you have access to it?
Should.
Actually,
Yeah.
why don't I read it and then you can respond to it?
Yeah. Okay.
Will you confirm IDPs are subcontracted by MTM and or part of the carved out NEMT services in Wisconsin? Had MTM rolled out IDPs in Wisconsin? Has the technology platform in use? Will, how, and when will this metadata be shared with HMO MCO plans?
Whole bunch of questions I'll put in there at the same time. So VEO, so when we acquired VEO, essentially the network that VEO had is essentially what we have now in Wisconsin. So prior to VEO having the contract in Wisconsin, we had, I would say but we had traditional IDPs, traditional transportation providers. Now that VEO is a part of MTM, they are in our network, and we're looking at in other markets as well. That technology, I think the question was how is the technology platform in use?
Yep.
It is today, and I think it's going to continue to grow. Is it super easy? No. I mean, anytime you get a new computer, a new phone, you have to go through some hurdles and whatnot. But by and large, I think it's working, and we've shown it, and it can work in a lot of different markets. Yeah.
IDPs in Wisconsin, do you know that's on the next? We don't have IDPs currently here.
Correct. Yeah. Correct. Next phase. Yeah. It is a newer concept. I mean, I remember when Uber and Lyft were first getting into Medicaid. We were like, how is this going to work? And there's going to be some bumps in the road. There's going to be some regulations that we're going to work with agencies to make sure we get through. So we'll continue to work on that in various markets.
Thanks for the question.
Yeah, it's a very good question.
As we're waiting, maybe one other, Phil, just comment to add as I'm thinking through this as well, and hopefully somebody, please feel free to ask another question. There's another element, I think, as we think about transportation that should be in the portfolio. We're thinking about the needs of the member, making sure there's flexibility for the member, making sure there's flexibility for the MCO and for the providers out there as well, so that we're really making those connections. I also think as we are in the Medicaid space, and obviously we are all, whether you're an MCO, a provider, an NEMT broker, a PBM, whatever you are in the Medicaid space, we ultimately are stewards of Medicaid dollars. Also realizing the benefit of these types of modalities and technology, particularly, to really maintain program integrity, because at the end of the day, good, solid program integrity ultimately benefits the member. That means that our providers are providing the right services in the right time at the right location. It means our MCOs are providing the right services at the right time at the right location. Same thing with our providers, right service, right time, right location. And as technology moves forward, I think it just adds more, whether it be a Medicaid program, legislature, whatever it might be, the being able to have that type of confidence that the dollars that are being invested in Medicaid, the resources that are we've been around a while, right? So the ebbs and flows of we've got enough, we don't have enough. It really comes down to making sure that the dollars are being spent most efficiently, and that they're really in line with program goals, program mission, and also program policies. So thinking about the technology, thinking about the platforms that are used, I wanted to also say, program integrity is a really important part of this equation, because again, we've all probably, unfortunately, read stories in the newspaper. Our plans have heard issues. And again, we're talking about a fraction of a percent, but we need to make sure, not just on the grievances side, but also as we think about the integrity of the program, how are we always staying one step ahead? How can we continue to do the data analytics? Because ultimately, it's the members that are going to be the ones that are going to benefit from a really strong program. So just something I wanted to, and to the conversation here, Phil.
Yeah, no, and that's why I appreciate your perspective, because your perspective comes from kind of at all angles. And I know that, I appreciate that. And you're right. I mean, again, everybody loves technology when it works and when they have access to it, et cetera. But to your point, there is still the stewardship that we have to be, very careful with kind of what and how we're doing in various markets. And
We're seeing if there's any other questions here, comments, thoughts, things we missed.
Yeah, I don't see anything. I think you guys covered it. I will say, if you guys have questions that you think of later, please don't hesitate to reach out to the NTM team directly. You can also reach out to us at MHPA. We'd be happy to connect you as well. So, it's definitely an ongoing conversation and a very important and evolving issue. So, this isn't obviously the end of the conversation. Hopefully this webinar isn't a referendum on the importance of technology as we move forward in the Medicaid space. But to that end, I will thank Kevin and Phil for the very important presentation. Like I said, it's obviously a really evolving issue, so I really appreciate them taking the time today to share their expertise. I think it was really beneficial for everybody. As a reminder, NTM will be sending out these slides as part of their follow-up communication, and you can find a recording of the webinar on MHPA's YouTube channel. Finally, I'd like to thank everyone who joined us this afternoon. I appreciate you taking the time out of your day. We hope that you found today's webinar valuable and plan to join us again for a future installment. With that, I'll thank everybody again, and we'll close out. Have a great afternoon, everybody.
Thanks, everybody.